Hello, everyone. Welcome to our Zoom meeting. Today, we're going to have different topics. Dr. Rahma and her team be presenting today. So I will give you Dr. Rahma when you have a chance. Please start. Thank you.
Okay, thank you, Dr. Nadir, for this opportunity. Hello, everyone. My name is Dr. Rahma, and I am G from Algeria. I will be moderating this meeting on behalf of the members of Team Pink. They will be covering the following subjects. First of all, Gait impairment. Secondly, institutional review board. Number 3, Canva tool. And 4, teaching skills. And the 5th subject is going to be poster presentation process. We're going to start by Gait impairment presented by Dr. Amna Alazraq. Are you ready, Dr. Amna? Okay, so I think we're gonna wait like for a couple of minutes until she comes.
Sure.
Okay, at this moment I will start sharing my screen for Gait impairment.
If Dr. Anna is not available, maybe we can start with two.
Okay.
Moayad Mudawi, if you are ready,
Mm-hmm.
you can start and then we can flip the order. So Gait impairment can be the second topic.
Okay, so Dr. Moayad, can you start?
Hello, sorry, I was having technical difficulties.
Okay, Dr. Amna, I will share again.
No, I'm Dr. Abeer. Me and Dr. Amna and I will both be doing the first presentation.
Okay. Go ahead, Dr. Abeer.
Okay. Can you make me a host so I can screen share my...
Right now?
Can you guys all see my screen?
Yes, we see it.
Yes.
Your phone to the side. Sometimes.
Okay, so Assalamu alaikum. Hello, everyone. Hello, Dr. Nadir. My name is Dr. Abeer Ahmed, and I'm a new fellow here, and I'm really happy to be here with you today. We'll be starting this session off with a presentation about gait impairment. This will be a shared presentation with Dr. Amna Alazraq. So today we're going to explore the essential aspect of human mobility, which is gait. It's the way we walk, or our gait, is something we often take for granted, yet it's a complex process involving the coordination of multiple systems in our body. This is why it's very important to know that a healthy gait is crucial for maintaining independence and quality of life, particularly as we age. So hopefully in this PowerPoint, our objectives is by the end of this PowerPoint, hopefully you guys will all understand how to know the different types of gait abnormalities and their causes, as well as their underlying etiology, how to perform a diagnostic evaluation of gait dysfunction, how to conduct a gait assessment of the elderly, as well as understand interventions that can possibly reduce gait impairment. So in this PowerPoint, the topics will be covered are epidemiology and conditions that contribute to gait impairment, as well as gait assessment and interventions to reduce gait disorders, which will be covered by Dr. Amna Alazraq. So starting off with the epidemiology, gait disorders are common and they're a predictor of our functional decline. Certain gait-related mobility disorders progress with age and are associated with morbidity and mortality. Common dwelling older adults with gait disorders, particularly neurological abnormal gaits, are at a higher risk of institutionalization as well as death. There are different types of gait abnormalities. Here is a few of the many types. We have the antalgic gait, which is a pain-induced limp with shortened stance phase of gait on the painful side. We have the circumduction, which is the outward swing of the leg in a semicircle from the hip. Circumduction gait is usually seen in patients with spastic hemiplegia. We also have the equina varus, which is excessive plantar flexion and inversion of the ankle. It's also known as the clubfoot. We have the fenestation, which means acceleration of the gait, where the fenestrated gait is usually seen in patients with, for example, Parkinsonism. Then we have the foot drop, which means loss of ankle dorsiflexion, secondary to weakness of ankle dorsiflexors, usually seen among patients with peripheral neuropathy. We have the foot slap, which is early frequent audible foot floor contact with steppage gait compensation. Then we have freezing of gait, which is also called frozen gait. This is a sudden short duration, diminution, or cessation of walking, usually associated with shift in attention or movement circumduction or direction. Then we have the genu recurvata, which is a knee joint deformity, meaning patients will have hyperextension of the knee. We have propulsion, which is the tendency to fall backward, and we have retropulsion, which is the opposite, tendency to fall back. Propulsion is the tendency to fall forward, while retropulsion is the tendency to fall backward. We have scissoring, which is usually seen in patients with spastic periparesis, like, for example, those with cerebral palsy. Patients will have hip adduction, such as the knees cross in front of each other with each step. Then we have steppage gait, where there's exaggerated hip flexion, knee extension, and foot lifting, usually accompanied by foot drop. Then we have the Trendelenburg gait, which is the shift of the trunk over the affected hip, which drops because of the hip abductor muscles weakness. So basically the hip abductors, there's a defective hip abduction, primarily caused by weakness in the medius and minimus muscle, causing the pelvis to fall and bend in the contralateral side while walking. And lastly, we have turn on block, where patients' whole body will be moving like one block. They will move the whole body while turning. There are many conditions contributing to gait disorders in primary care. They're usually multifactorial. They can be caused by conditions like degenerative joint disease or acquired musculoskeletal deformity or intermittent claudication or orthopedic surgery or stroke, postural hypertension or dementia or fear of falling or visual loss. Moving on to the classification of gait disorders. One way to classify gait disorders is based on the level of the involvement of the sensory motor system. They can be categorized based into low-level gait problems, or middle or high. The low-level gait impairments are caused by peripheral sensory dysfunction or peripheral motor dysfunction. The middle-level gait impairment are caused by postural and locomotor impairment, while the high levels are caused by cognitive and white matter disorders, which are problems in the brain. These levels may overlap when certain disorders involve multiple levels. For example, Parkinson's disease involving the high and middle structures, like the cortical and subcortical. So this is to emphasize that we cannot categorize a neurological problem based on like one classification. So diving into more depth, we have peripheral sensory dysfunction, which we mentioned was a low level. It can be caused by conditions like peripheral neuropathy or proprioceptive deficit. Patients will have either steppage gait, wide-based, unsteady, uncoordinated gait, especially without visual input. The patient may lift feet high and slap on the ground to increase sensory feedback. This can be demonstrated by negative This can be demonstrated by a negative Romberg sign because patients will have sensory ataxia. Clinically, patients will have loss of touch sense as well as loss of position sense. Another condition is vestibular disorders, where patients will have weaving, also called drunken gait, where they fall to one side. Clinically, patients will be in disequilibrium and have abnormal Romberg sign. It can also be caused by visual impairment, where patients will have a tentative, uncertain, uncoordinated gait with visual loss. So the peripheral motor dysfunction can be caused by conditions like painful or deforming conditions. Patients will have antalgic gait with shortened stance phase on the affected side. And they can have also a Trendelenburg gait, where there is buckling of the painful limb with weight bearing. Clinically, in clinical and physical examination, patients will have pain and decreased motion of the hip, knee, or spine, signs of arthritis, thoracic kyphosis, decreased lumbar lordosis, as well as a stooped posture. Another cause of peripheral motor dysfunction is focal myopathic or neuropathic weakness. This causes a Trendelenburg gait or waddling gait or steppage gait with foot drop or foot slap. Patients will have proximal muscle weakness, distal muscle weakness, exaggerated lumbar lordosis, which is secondary to the pelvic girdle weakness. Causes of postural and locomotor impairment are conditions like cerebellar ataxia. Patients will have wide base with increased trunk sway, irregular stepping, staggering, especially on the turns. Clinically, patients will have a poor trunk control, incoordination, or other cerebellar signs. Another cause is Parkinsonism, where patients will have small shuffling steps, hesitation, a fenestrated gait, propulsion, retropulsion, turn and block, absent arm swinging, as well as freezing of gait. On clinical and physical examinations, patient will have rigidity, bradykinesia, tremor, and stooped posture, all the characteristics of Parkinsonism. Hemiplegia or hemiparesis is also one of the causes of postural or locomotor impairment. Patients will have leg circumduction, loss of the arm swing, foot drag, or the scrape. On physical examination, patients will have arm and leg weakness, spasticity, equinovarus, and genorecurvatum. Paraplegia or paraparesis is another cause of postural and locomotor impairment. Patients will have bilateral leg circumduction, scraping feet, possibly also scissoring. On clinical physical examination, we will see leg weakness as well as spasticity. The third type, which is the high-level gait impairment caused by cognitive and white matter disorder, are conditions like frontal lobe disease or dementia or normal pressure hydrocephalus. Patients will have a range of gait abnormalities, which may include difficulty initiating the gait, freezing, like apraxia, shuffling gait similar to that seen in Parkinsonism disease, but with wider base, upright posture, and no arm swing. On clinical and physical examination findings, patients will have cognitive impairment, weakness and spasticity, as well as urinary incontinence. Patients with dementia, Alzheimer's disease, or vascular defects can have a cautious gait where they're careful with normal to widened base, shortened stride, decreased velocity, and also turn and block. On clinical and physical examination, patients will have mid to late stage dementia and may have fear of falling. Thank you, everyone. Dr. Amna Alazraq will carry on explaining the gait assessment and the cases. Thank you, everyone.
Thank you, Dr. Abeer. Dr. Amna, do you want me to share the screen?
Yes, you or Dr. Abeer, either one.
Okay, Dr. Amna.
Okay, I can finish sharing.
Okay, great. Hello, everyone. My name is Dr. Amna Alazraq. I will be presenting the next part of today's presentation. Thank you, Dr. Abeer, for explaining the term and the type of gait impairment. I will be giving you the gait assessment as well as possible treatment for gait impairment. And then we will have a couple of questions to make sure you understand the topic. All right. So to begin with, the gait assessment, we have key points that we should pay attention to. First of all, careful medical history and physical examination can elucidate. Can you hear me? Or I've heard some music.
Yeah, your voice is very clear.
Okay, great. Okay, so as I said, we have key points to pay attention to regarding the gait assessment. First of all, we must have a careful medical history and medical exam to elucidate all the contributing factors, as well to check for physical illnesses that may cause the gait impairment. Then we have lab and diagnostic imaging. It also depends on the history and physical exam. And again, we have a gait assessment tool. One of them is the time up and go. We will mention it in a couple of slides. Establish patient comfortable gait speed. We will also measure the gait speed. We can use both assessment and outcome measure. And finally, we have to remember that most gait disorders are associated with underlying diseases. All right, so to begin with, the history and physical exam, we have to evaluate for any evidence of subacute metabolic diseases, acute cardiopulmonary disorder, other acute illnesses. They can all reflect on the gait measure as well. We have to attempt to identify the motion-related factor. For example, we have to, we do a couple of tests to provoke the vestibular and the orthostatic responses. One of which is the Dix-Holbeck test for vestibular dysfunction. And we have to measure the orthostatic hypotension by using supine and standing blood pressure to exclude the orthostatic hypotension. We also need to do a vision screening, at least the acuity. So as the gait impairment might be due to visual disturbances. All right. Then we have to evaluate the neck, spine, extremities, and feet as well for pain and deformities, and if there is any limited range of motion, for example, contracture at the hip or knee joints. Then we have to measure the leg length discrepancies. We can just measure it from the anterior superior iliac spine to the medial malleus, just to see if there is any leg disturbances. Then a formal neurologic assessment is critical. We have to assess for the strength, tone, the usual neurologic assessment: strength, tone, sensation, including proprioception, and as well as coordination, as gait impairment may be due to cerebellar function deformity. Then the station and gaits as well. Romberg test can also be performed. Also, I can give you a clue of whether it's a cerebral dysfunction or not. Finally, we can do a cognitive function test, as it gait impairment may be related to cognitive impairment as well. After the physical assessment and history taken, we'll go to lab and imaging assessment. For the lab, we'll do the usual test, complete blood count, serum chemistry. We can also do other metabolic studies. In accordance to the history and physical examination that we have done, imaging may also be useful. We can perform head or spine imaging. It can be CT, radiography, or MRI. They're not always indicated, but it can be performed if you have any suspicion of a possible disease that may cause the gait disorder. Then we have the performance, the functional assessment. Okay, the first one is the gait speed. We have comfortable gait speed and related endurance measure. It's like a 6-minute walk. It's a powerful predictor of fall, disability, hospitalization, institutionalization, and mortality. The usual gait speed is tested by standing start over a distance of 4 meters. So basically, we just let the patient walk for a 4-meter distance, and then we will measure the speed. If the speed was 0.6 meters per second, it can be it's a proposed cut point for this mobility, or we can do further assessment. If the speed was more than 1 until 1.2 meters per second, it will have a better functional outcome, and it may have increased life expectancy as well. Okay, the time up and go test. So we basically record the overall time. We ask the patient to do a couple of tasks, and then we record the time and measure it. So what we ask the patient to do is to rise from chair, walk 3 meters, turn, return, and sit back in the chair. One study suggests it's the time up and go test. If it has a score of more than 14 seconds, that will be an indicator of fall risk. Meaning, if it's more than that, the patient may have more tendency to fall. Other studies have found limitation in the test, in the presence of cognitive impairment and difficulty in completing the test. If patients have cognitive impairment, he may have or she may have difficulty continuing the test, which may affect the results. Okay, then we'll go to the intervention. How can we reduce the gait disorder? Many conditions, such as many conditions causing gait disorder, are at best only partially treatable. Not all of them are treatable, but we must find out the root or the cause of the gait disorder and try to at least alleviate the pain of the patient, or try to improve their movement. Other outcome, like the pain reduction, may also be important and justifying the treatment. Comorbidity, disease severity, and the overall health status tends to strongly influence the outcome. So yeah, it's an overall assessment. Functional improvements become the treatment goal. Well, improvement of the patient life. The first one of which is the exercise and physical therapy. If the patient is having osteoarthritis, for example, knee osteoarthritis, the strength, flexibility, and aerobic exercises can help the overall outcome or improve the overall function of the knee. Post-stroke, we have the treadmill training. It may improve the gait, the speed, and walking endurance. Electromechanical and robotic assistance may also increase the likelihood of walking post-stroke, as you all know. In patients with Parkinson's disease, physical therapy can help the patient greatly, including complementary treatment. It can improve or shortly improve the functional mobility and the gait speed. The physical therapy will be mainly trying to increase the patient's strength, the whole overall balance for the Parkinson's diseases. There's also the gait disorders that may be secondary to B12 deficiency or folate deficiency, thyroid diseases, knee osteoarthritis, and Parkinson. All of those might improve with the medical therapy. We also have surgery options. For example, lumbar stenosis. Many have reduced pain after performing the surgery. However, there is also non-operative treatment that can result in improvement, such as water tolerance. The normal pressure hydrocephalus, they might also have short-term gait improvement after shunt placement, but the improvement will not be long-term. Hip and knee replacement or for osteoarthritis can also result in pain relief and gain in the gait speed and motion. But it also need a multidisciplinary rehabilitation, either prior or after the surgery, to have a more positive outcomes. The patient can also use mobility aids, for example, left, whether internal or external, to correct a limb strength, the limb length, inequality, and gradually improve the patient walking. We have also ankle braces through insert, through body and sole modifications. We can also use walking shoes with low heel, firm and thin firm soles, and if feasible, the high fixed heel collar supports. Cane and walker can also be used. They can also reduce the loads on the painful joints, and light touch on a wall or furniture circling. The patient can lean on the wall, can enhance the balance. Okay, that was the mobility aid. Okay, to summarize, the gait disorder are common in older adults and are predictor of a functional decline. The cause of gait impairment in older adults is usually multifactorial. Therefore, a full assessment is needed. It must include consideration of a number of different causes, as determined from detailed physical examination and functional performance evaluation. Various interventions, ranging from medical, surgical, and exercises, can reduce the degree of impairment, although some residual impairment is often present. Yeah, right. Then we have the cases. Okay, so I need everyone to pay attention. The first case is a 78-year-old man came to the office accompanied by his daughter, who is concerned about his frequent falls. She says that he tends to fall when he is away from home. He does not fall often in his house. The patient is unconcerned about the falls. In examination, the blood pressure and heart rate are normal, including postural responses. Visual, vestibular, and peripheral sensation are normal. Muscle strength, motion, and endurance are normal. There is no rigidity or abnormal resistance to passive motion of the joints. Gait speed is 1.18 meter per second. Okay, pay attention to the number. He steps with no difficulty over an obstacle placed in his path, with a few small steps when approach. Right? He does not make appropriate adjustment to maneuver past furniture in the exam room or past other in the hallway. Which of the following is most likely to be a factor in his fall? Is it A, cognitive dysfunction, B, cerebellar disorder, C, Parkinson's disease or Parkinsonism syndrome, D, spinal stenosis? Okay, what's your guys think? You can write it, chat. All right. Can you answer, please? Okay, Parkinson. All right. Okay. Okay, the correct answer is A. Actually, it's cognitive dysfunction. Okay, this patient has difficulties related to motor planning. He does not navigate around furniture or adapt to changing condition in his environment. For example, there's other along his path, which might indicate cognitive impairment. He has inability to adapt or adjust his movement as needed. So just that cognitive dysfunction may be a factor in his fall, that he is more likely to fall away from home in less familiar places. So yeah, that's one of the points. And his lack of concern about falls are a common feature of mild cognitive impairment. He has little insight to his cognitive difficulties and thus walks freely, falls frequently, and yet remains unafraid of falling again. He has no deficit in muscle force, motion, or endurance in relation to walking. A problem with cerebellar illusion is unlikely given normal findings in a sensory examination and his postural response to perturbation. The lack of sensory changes, muscle strength deficits, and pain or altered posture, for example, forward flexed trunk, argue against spinal stenosis. as a contributor to foot control. Walking is complex. Multiple limbs move in a different direction while the body progresses forward in the direction of intent using a rhythm pattern of stepping integrated with posture of the trunk and various phases of gait, all of which happen in an environment that may include changing condition and barriers. The factor characteristic of motor control include muscle action in walking, use of energy for walking, force to propel the body, stability, and maneuvering. Neural control to use the movement-related feedback and to integrate components and environmental changes. Eyes, wind, distractions that require appropriate gait adjustment while the walker remain in a mindful of his or her intent. Most of these factors occur without the patient direct focus, because gait can be affected by changes in any of the involved body system assessment, including an examination of the effector system, the muscle, the motion, force, and pull, information about the environment and moving within the ward, somatosensory, vision, and vestibular, and the brain use of the information available to adapt to the changes can affect the gait. So, and that's why the answer is A. Gait and cognitive problem are independently associated with an increased fall risk for older adults. Let's move on to case 2. We have an 82 years old man is concerned that his activity is increasingly limited since he fell 6 months ago. After he suddenly lost his balance, he is reluctant to go out socially for shopping or lunch. Since his fall, he has had several near falls despite being very careful. He reports no dizziness or unsteadiness when he sits. At home, he holds onto furniture for support and confidence. His history: he has osteoarthritis, diabetes mellitus, hypertension. He had bilateral total hip replacement 5 years ago on the right side, and 2 years ago on the left side. In examination, his blood pressure is 148/78. The heart rate is 72 beat per minute. He uses his arm to stand from a sitting position. He is mildly lightheaded for less than 30 seconds when he first stands, right? Visual acuity is 20/30 as best correction. Normal hearing and cognitive and cranial nerve finding, Northern side. Vibratory thumb diminished bilaterally in atrial and ankle. The strength is normal except in the hip abductors, 4/5, unchanged since the exam was conducted 4 months ago. He walked without an assistant device at a speed of 0.63 meter per second. Base of support is wide and he takes small steps. There is no Trendelenburg gait pattern. He has difficulty turning and walking along a curved path, but not when he walks on a straight path. He occasionally reaches for rail in the hallway. The lab finding: he has hemoglobin A1C of 8.2. Which of the following is the strongest contributor to his gait impairment? Is it A, hip abductor weakness, B, peripheral neuropathy, C, orthostatic hypotension, D, cognitive impairment? You may notice they all present in the patient, but which is the strongest contributor? Right, you can answer in the chat. Right. We have A, an answer. What do you guys think? Okay, mostly A. Right. So the correct answer is actually B, the peripheral neuropathy. Okay, the patient has a history of diabetes mellitus, so neuropathy is likely cause of this patient gait impairment. His gait is characterized by short step, slow speed, and difficulty turning. Persons with neuropathy often increase their base of support and become more cautious because they have diminished proprioception input from the feet. Gait impairment related to weakness of hip abductor would most likely be manifested as a Trendelenburg gait, which the patient does not have. Additionally, the decline in gait function has occurred over the past year because his hip weakness is unchanged from the previous examination. It may be a lingering effect from a joint replacement done 5 and 2 years ago, respectively. Orthostatic hypotension is not a likely contributor to this patient gait dysfunction. He has mild lightheadedness when he stands, but it resolves quickly, indicating that any postural changes of perfusion are quickly compensated. Orthostatic hypotension does not directly contribute to gait impairment per se, rather it contributes to falls via the pre-syncopal or pre-syncopal episodes that occur upon standing. This patient impairment is present when he walks, not when he stands. Okay. Studies of physical performances in individuals with mild cognitive impairment support the notion that impaired physical performance is present before the onset of dementia, especially in older adults who demonstrate executive function. However, this patient normal cognitive finding may make a cognitive impairment unlikely cause of his gait impairment. Therefore, the correct answer, as we said, is B, peripheral neuropathy. Okay, the third case, we have a 78 years old man. He is seen for follow-up related to gout in his related to gout in his first metatarsopharyngeal joint. He has not had gout pain for 2 weeks. He fell in his house twice in the past 2 weeks when doing his regular activity. He did not lose consciousness and does not know why he fell or why he fell. He was not injured. The history, we have hypertension, bronchitis, and osteoarthritis. He walks barefoot at home to avoid pressure on his right first metatarsal joint, and he is wearing sandals today. Okay. In the examination, supine, his blood pressure is 146/78. His heart rate is 85 beats per minute. The oxygen saturation is 95%. After standing for 3 minutes, his blood pressure dropped to 135/76. And the heart rate was 90 beats per minute, and his oxygen saturation was 96%. Intact cognition, sensation, and visual field. Visual acuity corrected with bifocal lenses. The DIX Holbeck maneuver, negative for dizziness or nystagmus. His range of motion is normal except for stiffness at the end range for hip flexion. Strength is 5/5 for all lower extremities, major muscle group. Bilateral hallux valgus with no redness, swelling, or tenderness of the right first metatarsal joint. His gait speed is 1.1 meter per second. Which of the following intervention is most likely to decrease his overall risk of fall? A, present to improve peripheral vision. B, treatment of orthostatic hypotension. C, referral to community-based exercise program. D, footwear modification. Okay, you can answer in the chat. What do you think? Okay, have different answers. Right, so we have mostly D, which is the correct answer. D is the right answer is footwear modification. Improper footwear is associated with fall in older adults. Studies show that older adults often wear slippers or socks or walk barefoot at home. Sandals generally often offer little support and may be similar to walking barefoot. Prism are used to improve the peripheral vision, particularly for persons with monomus hymenopia, a condition that results in visual field cuts on the right or left side. Affected person may bump into people or objects on the side of the defect, which may lead to increased accidental fall. This patient visual field is intact, and the history and examination findings do not support this cause. Orthostatic hypotension is defined as 20/10 millimercury drop in blood pressure when moving from supine to standing position. Ideally, the second blood pressure measurement should be taken 2 minutes after the patient stands. Although this patient blood pressure does drop when he stands, the changes does not meet the criteria for orthostatic hypotension. Additionally, the patient history does not include lightheadedness, dizziness, or loss of consciousness, and his fall do not occur when he stands, again, like the previous case. A community-based exercise program may benefit this patient for fall prevention, but the first intervention should still be to modify his footwear. Okay, that's the correct answer. Thank you guys for following the presentation. have ended. We hope that you have benefit from today's session. If you have any question, you can mention them in the chat.
Thank you, Dr. Amna, for this presentation. Thank you, Dr. Abeer. This is important subject, especially when diagnosing and treating geriatric population. Now we will be covering our second topic, which is Institutional Review Board by Dr. Moayad Mudawi. Dr. Moayad, are you ready to present?
Hello, yes.
Okay, do you want me to share screen?
Yes, please.
Okay.
Bismillah wa salatu wassalamu ala Rasulullah. Firstly, hello, doctors. I would like to thank Dr. Nadir to giving us this opportunity. Before I proceed, my voice is clear?
Yes, Dr.
Okay,
Moayad is clear.
okay. Well, hello, doctors again. My name is Dr. Moayad. I am a general practitioner, graduate from Al-Razi University, and now SFMG certified, alhamdulillah. Today, I will present an important topic about IRB, which is called Institution Review Board. The presentation, I will take it from the UCF, University of Central Florida, slides overview of IRB. So before we start the first element of our topic today, let me give you a brief introduction, describe what is IRB. So IRB, which is called Institutional Review Board, it is independent institutional review board made up of doctors, scientists, and lay people as well, who are dedicated to making sure that people who get involved in clinical trials or any research that involve human subjects are not exposed to any unnecessary risk. So by this, I would like to now to start by function of IRB. As it is clear from my introduction, the purpose of an IRB is to review research involving human subjects to ensure their rights and welfare are adequately protected. Okay, next slide. Okay, the role of IRB members, there is a member for IRB's institution, shared with safeguarding the rights and welfare of human subjects. Duties include reviewing protocols that involve the use of human subjects, assist and guide researchers to help protect the rights of human subjects. So, what about research ethics? What about research ethics and relation with IRB? The IRB makes sure that studies meet the ethical principles. So as we know, what is the ethical principles? One, respect for person, autonomy. Second, beneficence. Third, openly share and minimize harm or harmless. And the last thing, and fourth, justice. So IRB make sure that this ethical principle involved in any research involves human subjects to protect human subjects and their welfare. Okay. So why do human research subjects need protection? This is an important question that make to us now this IRB institution. There is a lot of triggers events that happens before in history that lead to make to us this institution review board, IRB. This triggers events like the Nazi experiments, Tuskegee syphilis study. I think last week, Dr. Sakshi, I hope I said the name correctly, told us about Tuskegee syphilis study and show us a video from YouTube about this big unethical bias that harm research participants in USA for African American. Number three, there is also studies like Milligram studies, Rosenhan studies, and Load Hembris. So, as I told you, trigger events, what we have learned from history that make us now to protect human subjects in research. like one Nazi experimentation on concentration camp prisoner, use a prisoner and use him in some research without respect their autonomy or any ethical principles. Second, to Tuskegee syphilis studies, as last week Dr. Sakshi showed to us a video, milligram studies and other studies. Okay, this is the question: do we have a right to use information gathered unethically? So I searched about this and I found a great answer from one professor. He said, this is a complex ethical questions without a simple answer. There are valid arguments on both sides. There is a valid argument on both sides. On one hand, there is agree with this answer could be seen as a further validating and potentially encourage unethical practice. So they refuse to use information gathered unethically. On other hand, they said it may contain valuable insight that could lead to important scientific advancement. So they agreed to use this information in certain situations. Ultimately, it's come down to carefully weighing the potential benefit of using the data against the ethical cost. Like which unethically information gathered, like we have an example here, prisoner for war camp in Asia. Please, the above slide, please. No, the back, previous slide. Yes, this. Down, please. Just here, yeah. Prisoner of war camp in Asia and Europe, like practice mutilation surgery, how we can use this unethical information gathered, like tested antibiotics, effective cold, injured people to study the healing process, and etc. Okay, we go now to the Tuskegee experiment. What physical harm happened? In 1932, took 625 black males, African American, and studied the course of syphilis. 425 were diagnosed as having syphilis, and the remainder were used as a control. In 1937, we discovered penicillin, but still did not give it to the men. So in this studies, one of the events that triggered the formation of the Institution Review Board to protect human subject. Next slide. Milligram studies, deception, emotional harm. In milligram studies, participants were asked to administer shocks to a subject who they believed to be a student when the subject answered a question incorrectly, compared to a Nazi war soldier who said, "I just did what they ordered me to do." Was this a true statement? Subjects were told to give what they believed to be painful shocks. About 75 continued, and even though they didn't want to, they continued to give the shock until they told they were approaching the lethal level. Subjects were devastated by what they were capable of doing. We go to the next studies, Rosenhan studies. In the Rosenhan study 1973 on being seen in insane places, researchers admitted to mental health institutions, claimed to hear voices. Once admitted, no symptoms reported, but still not released for months. Next studies, Lord Humphreys studies homosexual behavior in public restrooms, served as a watch queen. So he could watch and record what they did. Got license plate numbers and interviewed them for more information without their knowing. So here break some of the ethical principles. He did keep the identities and secrets, but is this enough? So now we will go to ethical milestones. In ethical milestones, there is code established like Nuremberg code after the Nuremberg doctor trials. There is trials happened in the 1947 called Nuremberg doctor trials. From these trials, human consent is essential. They reach to do essentially to take human consent for any participant. In 1974, first bioethical commission to shape human subject research. It's called National Commission for Protection of Human Subject Biomedical and Behavior. And also in 1978, there is Impairment Report and 1991 Common Rules. And this is the two important one we talk about in the next slide. First, the Impairment Report created ethical principles and guidelines for protection of human subjects in April 1979. Respect for personal, which called autonomy. People should be autonomous and not use it as a means to an end. Allow informed choice where participants can choose for themselves. Provide additional protections for those who need it. Drive it concept like informed concept, respect for privacy. Second ethical principle, beneficence. Do good. We are obligated to protect persons from harm by clearly identifying and maximizing anticipated benefits while minimizing possible risk of harm. Drive it concept like good research design, competent investigators, favorable risk-benefit analysis. Third, ethical principles called justice, and to be fair, require that benefits and burdens of research be distributed fairly. Drive it concept like equitable selection of subjects. So, federal regulations in 1974, there is a law from federal regulations, 45 central federal regulation, or code for federal regulations, called 45 CFR 46. It is a law set by U.S. Department of Health and Human Service for human subject protections. In 1991, the common rule, and what I would like to talk about it now in the next slide. Common rule, please. Common rules, a federal policy regarding human subjects protection that applies to 17 federal agencies and offices. Applies to agencies that have signed an agreement to uphold. Outline the requirement for assuring compliance by research institutions. Outline the requirement for researcher obtaining and documenting informed consent. Requirement for institution review board membership, function, operations, review of research, and record keeping. Also, and finally, outline protections for vulnerable populations. And this subclassified to sub-parts from B to D. Next slide. This is what we call the 45 CFR 46, the law created by U.S. Department of Health and Human Subject Service for human subject protection. Subpart A, federal policy for the protection of human subjects, what's called common rule. Subpart B, additional Department of Health and Human Service protections pertaining to research, development, and related activities involving fetus and pregnant women and human in vitro fertilization. Subpart C, additional DHHS protections pertaining to biomedical and behavioral research involving prisoners as subjects. Subpart D, for children involved as subjects in the research. So in summary, protective mechanism that established by the common rule 45 CFR 46 law. 1, institution assurance of compliance. 2, review of research by an IRB, an institution called IRB, Institution Review Board. And third and last thing, informed consent of subjects. So what is institution assurance? University of Central Florida has negotiated with the Office for Human Research Protection that all of institutions' human subject research activities, regardless of funding, will be guided by the Belmont Report, will comply with the common rules and other regulations as applicable. This is referred to as federal-wide assurance. So why compliance important? Compliance is important for professional ethics, states compliance for publications, for individual grant funding, for university grant funding, for any university researches, for liability. University of Central Florida has received accreditation of its human research protection. What is this accreditation? Accreditation by the Association for the Accreditation of Human Research Protection Program, called and simplified by AAHRPP. It is the gold standard that signifies that UCFF, or University of Central Florida, is in full compliance with regulatory requirements as well as industry-based practice. By this, I mean analogs to Association for Assessment, accreditation for of Laboratory Animal Care International, accreditation for animal researches, demonstrate commitment to human subject protection. So next slide. So this accreditation offers benefit to researchers. One of it, better standing in competition for funding. Second, recognition of importance by governments, private sponsors. Also, easier collaboration with other accredited accreditations organizations like veterinary administration hospitals. Okay. How do I know if a project needs IRB review? This is an important question. This can give us the cornerstones of our presentation today. How do I know if a project needs IRB review? Must meet two things to be to know if the project needs IRB review or not. One of the things to meet federal definition of research, systematic investigation designed to develop or contribute to generalizable knowledge. And the second one, and the important one, must meet definition of human subjects. The investigator will gather data about living individuals through the intervention or interaction, or the investigator will gather data about living individuals that is private and identifiable. So what's the criteria for IRB approval? One of the criteria, risks are minimized. As we said before, IRB make sure that studies meet the ethical principle, harmless. Second, the risks are reasonable in relation to benefits, beneficence, selection of subjects equitable, like what we said, justice. Informed consent will be sought. Informed consent also will be documented. Monitoring for data collected to ensure safety of the subjects, protect the privacy of the subjects, and maintain confidentiality. And additional safeguards need to be included in the protocol to protect the rights and welfare of the subjects. Next slide. So IRB, how IRB review of research. Our research projects are categorized into one of three categories for the IRB review process. Each category is different in level of scrutiny and submission procedures. The IRB is responsible for making the final decision of which category a research project falls under. Like one of the categories, full board review, expedited, exempt. In exempt category, there is some researches can be approved without IRB review. So now I will talk about the expedited categories reviewed by chair IRB designed member. In expedited, minimal risk and fit into expedited category, document review, survey or interviews, collection of specimen, routine non-invasive procedure. There's sort type of some research sorted in these categories, expedited. Okay. Minimal risk definition. What's the minimal risk in this category, in expedited category? Minimal risk is the probability and magnitude of physical and psychological harm that is normally encountered in the daily lives, or in the routine medical, dental, or psychological examination of healthy persons. Now for the last category, full board protocol review. This category or full board protocol review, protocols which meet the definition of more than minimal risk in the expedited. Principal investigator is invited to meeting to clarify the IRB concerns. University of Central Florida IRB meets once a month. So the IRB has the authority to, of course, has authority to approve any research that involves human subjects, to require modifications prior to approval, to table until major issues are clarified, to disapprove all research activities, including proposed changes in previously approved human subject research. There is required training from CITI, which is called Collaborative Institutional Training Initiative. It is online human subject protection training is required every 3 years. Study will not approve it until the study personnel are trained. By that I mean required training, that means investigators and study personnel doing research involving human subject must take the CITI training before receiving the IRB approval and become recertified at minimum every 3 years. So at the end, I hope I give you some of information about the IRB. And again, thank you for giving me this opportunity. I'm happy to be here today. Thank you for our audience.
Thank you, Dr. Moayad, for this interesting subject. Congratulations for getting certified. Good luck on the rest of your journey. Now we are moving to the next subject, which is a Canva tool presented by Dr. Mohamed Alasfari. Dr. Mohamed, are you ready?
Yes, Dr. Rahma, hello. Can you hear me?
Okay. Yes, I can hear you. Go ahead.
Okay. I'm going to share my screen. Okay, can you see it?
Yes.
Hello, can you see my screen?
Yes, we can see it.
Okay, so hello and welcome everybody. My name is Dr. Mohamed Alasfari. I'm going to be your presenter today. Before we go any further, I want to thank Dr. Nader for giving us and learn different knowledge and different information. So thank you, Dr. Nader. So today we're going to talk about Canva tool. It's going to be a short tutorial. Canva tool can be used by a teacher, a doctor, or an employee. It's like a PowerPoint, but it's on steroid. All of the things that I'm going to talk about today are free of charge with the crown logo on, like this one here. It's going to be for the Canva Pro, which needs to be paid to get. skills.Dr. We're going to have this bar show up. There's a lot of things that you can use Canva for, but I'm going to talk about presentation today. So if you press for presentation, we're going to go for this page. There's a lot of things that we can do using Canva tool. First of all, on the left side, we have the design. There's a lot of templates, layouts, and the styles that you can choose from. Again, there are some templates that you need to pay for to get. So, for example, here I use this type of template, and you can write whatever you want on the slide. You can use a different, increase the font size, and do many things for the phrases. For example, first of all, I'm going to demonstrate here the animation that you can do. For example, you can try to make it like basic, make it rise or pan or even fade. You can also create your own like this, for example, and it will move the same way you drag it. Of course, there's a lot of things that you can do with these things, and I'm gonna let you do this when we finish, because it's really something fun to explore. Another thing that I want to mention here that here the elements, you can add any graph or photo or video for your presentation. For example, here I search for medicine, so I can drag any photo here and put it in the slide. You can zoom in, zoom out, increase in size. Everything here, you can bring it from the search bar here. You can search whatever you want. Also, if you want to remove anything that you did, you just can do Control Z and everything will do. Or shortcuts, you can just go. Thing that here you can do, for example, when you put a photo here, for example, you can drag any photo, you can go to uploads and try to put the photo you want. So we're gonna take this one, sorry. Let me just delete it. So you press on this photo. First of all, let's talk about this photo first. So this photo, if you can drag it, you can sit down, and if you press on the photo for twice, so you can drag the audience to see. So this is really something that amazed me. These things the PowerPoint doesn't have. So this is really cool. Also, as we said earlier, I can drag this photo and put it instead of this last lady photo. And also you can press twice and then you can edit the photo or rotate it or whatever you want. Of course, Control Z, we can delete, undo what we did before. Another thing that I want to talk about is the text. There's a lot of combination that we can use for text. For example, you press this one, this combination selected, and try to write whatever you want. It will give us the same thing, a new slide. You can add a heading or subheading. This is all things that you can try once we finish this presentation. One thing that I found really amazing is the magic right here. If we like, for example, we have an introduction, awakening creativity. If you press magic right, I want this phrase to be more formal or more fun. So we'll try more fun, and they would going to give you some suggestion for doing the presentation more interesting. Again, Control Z will undo this. So you can try to create different phrases by using this. Another thing that we can do here is the duration. So when you're doing a presentation, and you have limited time, you can try to make each slide to have its own time. For example, here, the duration, I put the duration here. I will choose this one, duration. It's 5 seconds. So I can change it for 20, 30, whatever I want, or I can change it to 1 second. So this depends on the importance of the slide. This is something really good. Another thing that you can do here is that you can try to put your notes, and these notes will be displayed in the presenter view. I'm going to talk about presenter view after notes here. While you're doing your presentation, this is going to be very helpful for the presenter. Now, let's talk about the presentation here. So as we said earlier, there's a presenter view that you can try. Unfortunately, I think I cannot do this right now because I'm already sharing my screen right now because I'm and right.
Doctor, sorry for interrupting you, Dr. Mohamed,
important note
but
that
your
you need when you're doing the presentation. Another thing that you can do here is, yes.
We're having interruption in your voice.
Sorry, doctor, can you hear me?
Yeah, we can hear you, but there is a lot of interruptions.
Can you hear me right now?
Yes.
Oh, maybe from the internet connection. I'm so sorry for that. How about now?
Yes.
Is it better?
Yeah, it's better.
Shall I continue?
Yes, go ahead.
Okay, as we can see here, we can try. We can let other people access our presentation. So if we are doing a group presentation, we can add the emails here in order to access the presentation. So each one of us can do. This is really helpful. Also, that we can let other people join us by email. Lastly, that I want to talk about, we can copy a link and send it to others. We can download it and send it via social media. For example, we can send it via, we can share it via Instagram, TikTok, Facebook, everything here. It's really interesting. You can a QR code that will help us presentation to others by only scanning our QR code. So, for example, do like copy, we can put paste. And there we go. We have the QR code in order for other people just scan the code and get the presentation more easily. You can here also try to present and record. You can record yourself presenting. So this is very good for creating a self-guided presentation. And that's all for today. One thing I forgot to mention is the draw here. You can use this for a live presentation. You can highlight things, you can write them down, or you can write using the pencil. This is better for a live presentation, I think. But all these tools are very helpful for our life as doctors or as people who wants to do a presentation, research, etc. So I think I hope this presentation was very good and helpful to you. And thank you for your time and attention.
Thank you, Dr. Mohamed, for covering this topic. Maybe we can use it to help us into creating professional and visually appealing documents in this residency application like CV or personal statement. Now, we start the fourth topic, which is teaching skills by Dr. Lojain Abdelfadeel. Dr. Lojain, are you there?
Yeah, this is me. Hello, Dr. Rahma.
Hello, okay. So do you want me to share my screen?
No, I want to share my screen.
Okay.
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 So the screen is visible for you now?
Yes.
Okay. So hello everyone. Hope you all are all doing well. This is Dr. Lojain. I am honored to be here to share with you a presentation on effective teaching techniques and methods. And thank you for taking time to join me. Okay. Today I'm talking about the teaching learning process and teaching techniques. Here in the session outline, we will have a brief introduction. Then we have a definitions of term related to teaching learning process. Then I will talk about teaching methods, principles of effective teaching and learning process. And finally, I will talk about the events of learning. Okay, what is the teaching? Teaching is a process of interacting. It's a process of engaging students or learner in activities that will enable them to acquire the knowledge skills as well as worthwhile values and attitudes. Okay. So the teaching approach, now I will talk about the teaching approach. The teaching approach is the set of the principles, beliefs or ideas about the nature of the learning and which is translated into the classroom or the sessions. And here I will provide you some examples about teaching approach. Teaching approach like teacher-centered, subject matter-centered, teacher-dominated, learner-centered, interactive, constructive, integrated, collaborative, and another example. There is a multiple examples of teaching approach. Then we're going to move to the teaching methods. Teaching methods are methods and strategies used by educator to facilitate learning and enhance student engagement. These techniques can vary widely depending on the subject matter, the age and needs of the students and goals of the lesson. And I will talk about some example of these teaching methods, like direct instruction methods. And direct instruction method, this involves the explicit teaching of a skills or concept by a teacher. It often include modeling, demonstration, and guided practice. Then we have inquiry-based learning, and this method encourages students to ask questions and explore topics on their own, with teacher acting as a facilitator rather than the primary source of information. Then we have a project-based learning, and here project-based learning involves students working on a project that require them to apply knowledge and skills to solve a real-world problem and to answer a complex question. Then we have a problem-based learning. The problem-based learning is similar to project-based learning, but the problem-based learning focuses on a student solving a problem, but it's often more structured and can be used in a variety of subjects. Then we have a cooperative learning. The cooperative learning, this is methods involve students working in small groups to achieve a common goal, and it promotes social skills, communication, and teamwork. Then we have a peer teaching. Peer teaching in this method involves a student working in all turn teaching to their peers. This can help reinforce the material for a student teacher and provide a new perspective for the learning. Then we have the discussion-based learning, and in these techniques involve facilitating discussion among the students to explore topics in depth. It encourages critical thinking and communication skills. We have also case study method that this type of methods we are used usually in our clinical grounds on a daily basis, and this is involving presenting students with a detailed scenario or case study and asking them to analyze and solve the problem presented. Okay. Then we have role playing, and here students act out roles to understand different perspectives to apply knowledge in a simulated environment. We have also mind mapping, and mind mapping, this is a visual technique to help a student to organize and structure information, make it easier to understand and remember. We have another examples of teaching method. We have more than 20 types of teaching methods, but those are the most important and really used in our daily basis. So now we're going to move to the process of teaching. We have a guiding principles in the selecting and use of teaching strategies. This guiding, it's depend on understanding the learning process mainly, okay? Learning is an active process, and we have to actively engage the learner in the learning activities if we want them to learn what we intend to teach. And the good teaching guidance or good teaching principles is what provide a higher rate of retention of information. So the researchers show that 75% rate of retention in the learning is that it's achieved by doing, and 90% of retention rates learning by teaching others. So also the research tell us that the most learning occur with sight, and which is occupy about 70-something% of the retention of the information. So the advice we should give here, when you want to give a highest rate of the retention of the information, you should use a combination of the methods like sight and hearing, as I am using here right now. I'm sharing slides, and at the same time I'm talking about the subject. So this is lead to a retention rate of more than 88%. Then we have the teaching process. The teaching process has the main 3 steps. First step is a plan, second step is implement, and the third step is evaluate. The first step, which is called a pre-active stage and also known as a planning stage. During this phase, we usually create a plan, okay? And this plan depends on the need of learner, the achievable goal and objectives to meet the needs, and the selection of the content to be taught, motivation to carry out with the goal, and approach most fit to carry out with the goals, and finally, the evaluation process to measure learning outcome. After that, we're gonna go to the second stage, which is the interactive stage or implementation stage. Based on objective, implementation means to put into action the different activities in order to achieve the objectives through the subject matter. An interaction of the teacher and learner is important in the accomplishment of the plan. And here we should use a different teaching style and strategies to reach the ultimate goal. And finally, we have stage 3, which is a post-active stage. And here also we can call it evaluation stage. Here we create a proper testing device and we gain back the feedback, okay? So the good teaching is one that is well planned and where the activities are interrelated to each other, goes beyond the recall of information, one that provides learning experiences or situation that will ensure understanding, application, and critical thinking. One where the learner is stimulated to think and reasons and apply, okay? Then we have the events of learning. The events of learning is starting from the inner drive to learn till the last stage or the last step, the feedback step. So we will start with motivation phase. During this phase, the learner must be motivated to learn by expectation that learning will be rewarding. Then we have apprehending phase, and this phase, the learner stands or pay attention if a learning has to take place. Then we have a question phase. While the learner is paying attention, the stage is set at the information presented. And then we're going to move to the retention phase, where the newly information must be transferred from the short-term memory to the long-term memory. And we have the recall phase, and in this phase, we will recall previously learned information. To learn, to gain access to what has been learned is a critical phase on learning. Then we have a generalization phase. In this phase, we transfer the information to the new situation and allow application of the learned information in the context in which it was learned. And finally, we're going to move to the feedback phase, where the students must receive feedback on their performance and assessment. And finally, the teaching is a multifaceted profession that plays a crucial role in shaping the future by educating and empowering students. It involved not just the transmission of knowledge, but also the facilitation of learning and development of critical thinking skills. and the nurturing of full-rounded individuals. Effective teaching requires a deep understanding of the subject matter and the ability to connect with the inspired student. So the home message here is the teaching is both an art and science. It demands creativity, empathy, and commitment to continuous improvement. As an educator, we must strive to create inclusive, supportive, and stimulating learning environments that challenge and inspire our students or learners, preparing them not just for academic success, but for life beyond the classroom. And that's all. I hope all of you enjoyed this learning.
Thank you, Dr. Lojain, for this presentation. This was a great subject. Surely teaching skills are both effectively in sharing knowledge and engaging students in inclusive environment. Now, Dr. Nada Dahroug will be presenting poster presentation process. Dr. Nada?
Hello, can you hear me?
Yes, Dr. Nada.
Okay, that's great. Okay, hello everyone. I just wanted to share some good news today. So our team, we did like a poster presentation in AAIC 2024, which is the Alzheimer's Association International Conference. And we received the best postdoctoral poster award. So that's why I wanted to come here today and kind of share the news first, and then afterwards I wanted to share the process. So hopefully it could be helpful to other people who are working on poster presentations. So I believe I have Dr. Nidhal here today. Thank you. I believe I have Dr. Nidhal here today. We worked together on the project. It was me, Dr. Nidhal, Dr. Mayra, and of course, Dr. Nader. So I'm gonna try and discuss as much as I can and remember about the process itself. And please, if you have any questions, feel free to stop me at any time. And Dr. Nidhal afterwards can share her opinion about the process because I might forget anything along the way. So I will just start. So in our case, we started working on the poster in January. And then we had a deadline, of course, so we had to be like on time. I think we had like a few days to work on it. So we had a case presentation that was very interesting, and I will just share my screen so you can have an idea about what was the poster itself. And if you have any opinion, any things you want to ask, just go ahead and ask them. So this is the online version of the conference, since I have access to it. So I'm just gonna share it from the conference itself. We did it virtually. So we used, as Dr. Mohammed just discussed today, the Canva. We used the Canva for the video and I felt like it was very helpful. And it just made everything much easier. Here you go. So this is the poster itself. You can see my screen?
Yes, Dr. Nada, we can see it.
Okay. There you go. This is the poster itself. And then we had the video for it. As you can see, it's just like it was in dementia care practice. So we got it in the non-interventional management of dementia. And this is the video itself. So as you can see, we did all of this with Canva. Just giving you an overview. As you can see, we have, in this case, in our case, all of the authors actually presented the poster itself. So as you can see, Dr. Mayra is here. Sadly, she wasn't able to join here today to share her experience, but I will let her know if she can. And this is for mine. And then afterwards, we have Dr. Nidhal. So as you can see, we used Canva to kind of do everything regarding this video. It was very helpful and very easy to use. Dr. Mohammed today has discussed it, and I've also done a tutorial about how I did this specific poster. I think it was in June or July. If you're interested, you can go back to the YouTube live for our meetings and you can go ahead and check it out. So let's start with sharing the process. So as I mentioned, in our case, we done it in January. We had a case presentation. It was like a case report about an interesting case. And then we worked together. So I think the most important thing is to have like your team with you, your team. In our case, we're almost friends at this point. Like we're friends. I wouldn't consider us teammates. We have worked so long together on this project. Everybody should be supportive in it. Everybody should give up their opinion. I think this was very helpful in our case. The three of us, we didn't do any step without going back and making sure everyone was okay with it before we go ahead with it. We had to do our abstracts first, so we submitted the abstract in January. Of course, I would recommend you all to thoroughly read like the abstract instructions in the specific conference you're applying to, because sometimes they have very specific things. Like for example, let's say you want to do the method first, you want to do it in a specific way. Sometimes they would mention they want it in a very specific way, and they would reject your abstract if it doesn't follow their guidelines. So please go ahead and try to adhere to it as much as you can. Also, I would recommend you to try and submit it at least if you can 1 day ahead of time, because in my case I did it on the same day in the morning and it was crashing a lot. So I would recommend you not to put yourself in that position. And then afterwards, we got our acceptance a few months afterwards, and then we started working on the poster. So I think the most important thing when you work on the poster is to have like a few like templates in mind. So I believe we used actually, Dr. Mayra helped us with the template. So we had one that previous fellows have used before, and we kind of changed it. So the one that you have seen isn't exactly the same as the one that we received from the previous fellows. We changed the colors, we changed a lot of things in it, and we used Canva as well actually to change the poster itself. And I remember Canva had templates. So you can go ahead and do as if you're doing a poster presentation from Canva, and then you could see different templates, and then you could put your data into it and see which one works out the best way. Because I would recommend you to, when you're working in a poster, you have to go ahead and read it a few times at least, and make sure there is nothing to take out of it. Like you want the least amount of information in the poster as much as you can, but at the same time has them like you still have the message of the poster in it. So that's what we worked on. Every time we'd meet up, I think we met almost once per week until we finished the poster, just to make sure that we're okay with it. We also took the feedback of different, like in my case, I'm working in Canada, so I took the opinion of a neurologist I was working with, and she told me, this color isn't the best. For example, you should remove this part. I've also taken Dr. Nader's opinion, and each of the team members tried to do that as much as we can. So I felt like this was helpful as well, having feedback from different people, because sometimes when you're working on something, you can't see your mistakes. You have been working on it for very long that you can't see any mistakes in it. You feel like there's something wrong, but you're not sure what it is exactly. So I would recommend you to do that as well. In our case, since we did it virtually, we didn't do it in person. So we had to do the video for it. They mentioned actually that the video was not like obligatory for you to do it, but I feel like if you have the option, go ahead and do it if you're doing virtual, because at the same time, like the audience would see your faces, because otherwise, if you don't put the video in, you just like see the names. So they wouldn't get like familiar with you as the presenter. In our cases, we wanted each of us to have the opportunity to present. So we did that. We were able to kind of
204-890.
We were able to kind of each of us we kind of divided it into introduction and objectives, one person, and then the case it was a lot, so one person, and then the results and what else? I think it was the results and the conclusions. Yes, the results and the conclusion was the last person. So I think this was a very good opportunity for each of us to try and present and do it in as much as we can from this experience as well. And then we uploaded the video, and then thankfully just a few days ago we just received that we did get the award for it. This was the good news. If you have any specific questions along the way, any like questions about the process, please go ahead and ask. Regarding the obstacles that we faced, I think it was mainly the poster itself. Like the poster itself, we weren't sure, is it the right way to do it? Should we do it in a different way? Are we doing any mistakes? So I feel like this was the main obstacle, and I feel like the thing that made us able to kind of agree on something is having all of these opinions. Like us three would sit down every time and not just like chat and not messaging, we would meet together and look at it and kind of discuss everything. And almost every time that we met, we would change something until the last time that we actually uploaded it. So I feel like having like cooperative teammates and people who want you to, like all of us want this to succeed. So I feel like this is really important. So choosing who you work with and everybody should be like, you don't do just your part and that's it. I feel like everybody should try and say their opinion as much as they can. And yeah, this would be like my experience with this, and it was a very lovely experience that I've learned a lot from, and I've gained amazing friends from this experience. Yeah, and if anyone has any questions, please go ahead and ask.
So thank you so much, Dr. Neda, for sharing
Thank you, Dr. Ned.
experience perspective. Dr. Mayra is not here, but Dr. Nidhal.
I think Dr. Nidhal is here. I think I've seen her. So if she's here, I would love to hear what she has to say as well.
Hello, everybody. Actually, there is nothing more I can add after Nada, but firstly, I want to thank Dr. Nadir because like he involved me in this project and he knows that I am very interested in neurology. And when this chance just pop up, he emailed me and I was very interested to contribute and to participate in this. And as Dr. Nada said, actually, we started at the fellows. We started as fellows, me, Nada, and Mayra, and now we are friends. Even you could say that we are very close now. And the main key of our success or why this worked just because of the teamwork. This was the key. We went through some conflicts because we have different opinions. Everybody wants his own opinion to be done in the project or in the poster, but because we were understanding everybody and we were like, we wanted this to work, that's why we were helping each other. And now we are honored by this award. And again, thank you very much, Dr. Nader. I'm very grateful for this opportunity, and I'm very happy and glad that I worked with such people. Thank you.
Thank you both, Dr. Nidhal and Dr. Neda, and congratulations. This is great news, great opportunity, and it's a big event, a big award. So congratulations, you did great. And with that, they don't pay money, but actually you are member of the Alzheimer's Association for 1 year for free. So congratulations and with that as well. So thank you both. And Mayra, you see how send her our congratulations as well. Any comments?
Thank you.
Yeah, go ahead. Go ahead.
As well, if anybody's interested in applying to the AIC for the next year, I would recommend, like we did, we didn't pay for the conference itself, so we each paid our own membership to be like ISTAART, I think that's how you say it, ISTAART, the membership of itself of like Alzheimer's Association. It was cheaper, and also you had like free access to the conference itself. So I would recommend anyone who's interested to do that instead of just paying for the conference without going ahead and doing the membership. Yes, that's my last advice. Thank you.
Thank you so much, both Dr. Neda and Dr. Nidhal for sharing. If you have any questions for both of them, you can email them the information on the app and you can contact them. Thank you. So with this part, I'd like to thank Dr. Rahma and our team, all the presenters for great presentations. You did a great job. We can move on to the last part of the program. Any updates or any questions, comments you want to share, please jump in or raise your hand. Go ahead, Dr. Tahir.
Hello, Dr. Nader.
Hello.
How are you?
Very good, thanks. Go ahead.
So, Doctor, there's a research project about bariatric surgery. The problem is that there is no one who knows how to do a systematic review. So I don't know if anyone here is interested in doing this type of research. If there's anyone who's interested in this, I would be more glad to participate in our project because we need 3 members right now.
Can you tell me more? Do you have a team or it's an idea? You just put it in or you already?
No, it's we already have a team. Yeah, the project is about long-term outcomes of bariatric surgery, the efficacy and the complication, and the quality of life improvements post-surgery. But the problem is that we don't have enough members, and there's no one who has any experience in systematic review.
So in that case, you can, as you mentioned, you can recruit some of the fellows who are interested. But I would, Dr. Nada, can you share the link for the big WhatsApp group? So if you can join the WhatsApp group, the big one, and ask for help, some of the seniors who presented or published using the method of systematic review might be of help to you. You can approach them in the WhatsApp group, or you can approach them using the publication list that we have so far. So we have different abstracts. They used the method of system. Any one of the seniors here?
Yes, Dr. Nader, I shared the link in the chat.
Thank you. Anyone with experience that can help Dr. Tahir and his team? I think Dr. Haifa, are you here? So perhaps Dr. Tahir, you can contact them via the WhatsApp group and someone will get in contact with you.
Okay, thank you, Dr. Nader.
You're welcome. So now the context. I'd like to share with you this also other good news. So one of the fellows in this group also has been accepted, Dr. Salamawet. She joined our program here, and on Monday, a few days ago, she was called by one of the program, residence program, and they gave her an interview, and she accepted the offer, and now she's starting this Monday. So this is what I'm trying to tell you guys. Some of the programs might have an planned position that's unfilled for many reasons. Some of them might be they accept a person from overseas, and if there are some problems with the visa, with the travel, with that person to come and join the program, they will be in need for someone to fill that gap. So usually in June, July, and August, some of the programs might have some unplanned open positions. So if you did not match and you have all the requirements to start residency, it's better to approach all the programs, for example, internal medicine or medicine or whatever, in May, July, and see if you can match. They ask her to come right away, so you must be available for either phone interview or, in her case, in-person interview. So she went, I think the next day she drove and she went to the program. She did her interview there. They accepted her right away. So some of the programs might be in this situation where they will be searching for someone to fill the gap or the position for them so that they can get the job done. Especially some small programs where they have a few residents, they will need that position to be filled. Actually, that's what happened to me when I joined the first year university. They had an open position also. Thank you. Congratulations to the president. Any other questions, any other comments, any other addition? Please feel free to jump in or raise your hand. So for new fellows or any fellow who is interested in doing project, please add yourself or just add a comment in the WhatsApp group. So some of the other fellows who are working on some of the projects might need your help. The other way is to look at the app and see if you are interested in one topic or one of the projects. In the app, you can create a team and then you can start the project. You can identify the task, what to do, and then divide these tasks between the team members. There are different methods of doing the projects. The end result might be just a poster or abstract that's submitted to a conference, like Nada and her team. They submitted to the annual conference for Alzheimer's Association. There are few conferences that are coming, so you can target some of these conferences with one of these abstracts. So you need to work on getting the abstract ready for them. Some of these conferences might accept the abstract in partial. You don't have to complete the whole abstract. They need the idea, so they need to get the background and what method you are doing. You don't have to present the data or the results at that time of submission. Later on, if they are interested in the topic, they can approach you and tell you, now you have, at this time, you can resubmit your application with the data, the results, and the final abstract format. They will review, and if they accept it, that then you can complete the poster presentation and you can present to that meeting. This happened to some of the fellows in this program. They applied or submitted their poster or abstract to American Geriatric Society meeting, and they got accepted for the partial abstract while they are working on getting the rest of the data, and they finish collecting the data and finish the abstract and submit it a few months later. That was accepted as well and presented in the annual conference. So some of the conferences might have this opportunity or this window. They can accept your work even if it's not a complete work. NAPGREC is the North American primary care group as well. They have two options. One option is to submit a completed abstract or project and accept it, or they can allow you to submit a work in progress abstract. So that means you have the idea, you have the method, and write this down, submit it, and in the meantime, you collect the data. Hopefully, the following year, you will be ready to submit your abstract and data conclusion. So you can get accepted for the same conference 2 times, 2 years before. So there are different ways of doing the project and presentation. The second way is to write the format as a paper. So you work on a manuscript, and target some journal, submit it. Sometimes you will need to pay for that submission. So the team can collect all together and pay for that. In the past, sometimes we have some fund, or we had, so we paid for some of the expenses. But currently we are seeking some funding. The third option is to get involved in the app development or mobile application development. So if there are some people who are working on developing some app, you can join these teams, or you can come up with your own idea of the.
I'm sorry, Dr. Nader. I think your voice is not clear now, and the message is not only for me.
Oh, sorry.
Yeah.
Sorry.
I saw that's only for me, but I put in the comment, and all of us, I think we cannot hear you well.
Oh, I'm
Raise
sorry.
your voice a little bit.
I'm sorry about that. So is that better now? Or you still have problem?
Yes, now I think it's much better.
Okay. So I was just talking
No.
about project. Can you hear me now?
Yes. Thank
Okay.
you.
So I just want everyone, if you have time to work on getting some task done by joining a project team, if there are some projects are going. In the WhatsApp group, you can approach the project leaders in the WhatsApp group. So if you want to join their team, if you want to come up with some new ideas, we have listed some new projects in the app. You can look at the project idea, you can modify the title, you can modify the method. It's just some list of new ideas with some projects. I used artificial intelligence to come up with some new areas that we can cover. So you can look at some of the projects in the app. That can be an idea for you. You can create the team, and the method can be systematic review. You can create different ways of you can do literature review, and maybe you can ask fellows and residents about a certain topic. So it's just an open for you to think about how you do your research project. You can create a team and ask the other fellows if they are interested. You can join a development like application, mobile application development team. You can come up with new ideas for new mobile application. So there are plenty of opportunity for you to get involved. One thing I can think about is if you are interested in a certain area, like Nidhal, she is interested in neurology, for instance, I would advise her or whoever interested in neurology to look at the neurology American meeting, the association where they meet annually. So there are some abstracts there. You can look at the abstract of this society and see how they present and what topics, because these are the most relevant for them and they already accepted them. So you look at the end of each of the topic or of the poster, they will say, we haven't finished the research yet, or we still there are some area for research. So you follow their lead, so you can see what area they did not finish and what possibility that you can do. Some of them might use a database set like they buy from the National Hospital Association or National Inpatient data set. So also you can create some of the abstract regarding inpatient medicine as well. So you want to look at that, and I don't think it's expensive to get the data. So there are plenty of options or opportunity for you guys to work on either new projects or you join some projects that are going on. Any questions, any comments?
Yes, Dr. Nader, I have a question.
Go ahead, Dr. Salma.
I'm not sure if this has been brought before, but sorry if it is a repeated question. Regarding the ERAS application in the experience section, how may I write about this to the geriatric fellowship, especially in the with the Michigan State University not being anymore, you know.
So you can look at the ERAS application copies of previous fellows. I think I shared that in the app, where you can look at previous fellows, what they describe their experience. And if your experience is similar, you can just copy paste. If it's different, you can just modify their answer. But basically, it's a comprehensive experience for you guys. I hope that you learn different things. So not only the research part and not only the geriatric aspect, but also the personal improvement, like your own skills as far as presentation skills, leadership skills, teamwork, team membership, or working with technology, as we were discussing today about Canva, how to present using this technology, using artificial intelligence, whatever experience that you think you gained, you can mention that in the section. If you are involved in a project, what's your role in that project? You were a team member or a team leader? What kind of task were you assigned? And what did you do with that project? How far did you submit and waiting for the results? Something like that.
Thank you.
You're welcome. So you can get any IRB approval. The question here is it okay to get hospital IRB approval? Yes, you can get the IRB approval from any body around you. So it could be from your hospital. It could be from an institution like a university. It could be from any body that look at your proposal and project and see if they can approve everything, and if they want to modify something, then they can advise you to modify your proposal. So, Dr. Adam, yes, you can get it from the hospital. You don't have to wait for the Ministry of Health. So, building connection with other fellows. So, my approach is to try to contact your friends, your colleagues in your university who match in the past year or a couple of years, and see if they can connect you with some of the programs there. Some of the fellows here match to either residency or fellowship. Also, you can try to approach them and see how you can fit and if they can help you with that. And the third option, some of the fellows presented some of the posters in conference where they go in person, and you can make connection in that way as well. So you can meet people in these conferences, and hopefully you can sell yourself, and someone might be able to help you. Okay, I'm gonna share with you the, I think the ERAS document. So in the chat, there is a link for the ERAS documents. This is for the fellows who got matched to either residency or fellowship in the past. I'd like to thank them for sharing their information or their documents. So you will find the personal statement there, and you'll find also a copy of their ERAS application. So you can review them and you can see how they answer questions. Any other questions? If not, I'd like to thank you all for attending this meeting. Thank you, Dr. Rahma, and your
Sorry, Dr.
Yes, go
Nader.
ahead. Go ahead, Dr.
Yeah, sorry, just we couldn't find the link in the group chat.
Oh, sorry. I sent it to Rahma. Let's see all how to do all.
I'm sending it in the group chat on WhatsApp.
Okay. So now you see it in the chat as well.
Okay, someone answered thank you, so I guess they are seeing it.
All right. Any other questions? Any other comments? If not, thank you all again. And thank you, Dr. Rahma. Thank you for everything. I wish you all the best. And I know this is a busy time for you. I wish you all the best and good luck. Thank you. Have a wonderful day or have night, wherever you are. Assalamu alaikum.
Thank you so much. Assalamu alaikum.
Thank you, Dr. Nader, for your time. Thank you.
Thank you.
Thank you.
Thank you, Dr. Nader.
Thanks.